Prevalence and impact. Statistics and prevalence in the UK population. Understanding how common learning disabilities and autism are in the UK is essential for care workers. It enables you to anticipate support needs, advocate for timely referrals, and make practical adjustments in care environments. Prevalence data also highlights gaps in services and helps drive equitable, person-centered planning. Learning disabilities, current picture. Headline estimates. Approximately 1.5 million people in the UK have a learning disability. Around 2% of adults are estimated to have a learning disability, though fewer than 1% are recorded on GP registers. Employment and welfare. Just 5 to 6% of adults known to local authorities are in paid work. People with learning disabilities are more likely to live in areas of high deprivation and face significant health and social inequalities. Healthcare access. Uptake of the annual health check for people with learning disabilities has improved, reaching nearly 80% of those eligible. Autism spectrum condition (ASC). Prevalence and diagnosis. Autism affects more than 1 in 100 people in the UK, approximately 700,000 individuals. The number of autism diagnoses has increased substantially in the last 2 decades, due to improved recognition and broadened diagnostic understanding. Assessment wait times. There are currently long waits for autism assessments, with tens of thousands of people awaiting diagnosis beyond NHS target times. Hospital care and admission. Many inpatient placements for mental health now involve individuals with autism, often without a co-occurring learning disability, reflecting gaps in community-based support. Overlap and dual diagnosis. About 1 in 3 people with a learning disability also deal with autism. People with dual diagnoses are more likely to experience complex support needs, mental health difficulties, and longer delays in accessing assessments or tailored care. Education, SEN and EHC plans in England. These figures confirm the importance of recognizing traits of autism and learning needs in children, particularly during transitions into adult care. Inequalities in access to healthcare and support. Despite advances in policy and awareness, people with learning disabilities and autism in the UK continue to face persistent and significant inequalities in access to healthcare and support. These disparities affect life expectancy, mental and physical health outcomes, and quality of life. For care workers, understanding these inequalities is essential to addressing them through person-centered care, advocacy, and inclusive practice. Health inequalities and early mortality. Evidence shows that individuals with learning disabilities die, on average, 20 years earlier than the general population. Many of these deaths are avoidable, often caused by delayed diagnosis, poor access to treatment, or mismanagement of existing conditions. Similarly, adults with autism, particularly those with co-occurring mental health conditions, are at heightened risk of suicide, undiagnosed illness, and poor long-term outcomes. Factors contributing to these disparities include lack of accessible communication during consultations, diagnostic overshadowing where symptoms are wrongly attributed to a person's disability, delays in referral or under-investigation of symptoms, inadequate reasonable adjustments during care. Barriers to accessing services. People with learning disabilities or autism often face challenges in navigating complex healthcare systems. These may include physical barriers, such as inaccessible facilities or sensory unfriendly environments. Communication barriers, including the use of medical jargon or lack of easy-read information. Attitudinal barriers, where professionals lack understanding or make assumptions. Administrative barriers, such as rigid appointment systems that do not allow extra time or flexibility. For example, a person with autism may avoid attending GP appointments due to the sensory overload of a waiting room, or a person with a learning disability may be unable to complete online referral forms without support. Impact on families and carers. Families and informal carers often act as gatekeepers to healthcare, supporting communication, transportation, and decision-making. However, when services fail to recognize or involve carers appropriately, this can add pressure, reduce effectiveness, and create further inequity. A lack of joined-up support between health, social care, and education services also leads to fragmented care and missed opportunities for early intervention. Underrepresentation and delayed diagnosis. Another significant issue is the underdiagnosis of autism in females and people from Black, Asian, and minority ethnic backgrounds. Cultural stigma, language barriers, and lack of culturally competent services often delay or prevent access to diagnostic pathways and tailored support. For instance, girls may mask traits of autism, leading to late or missed diagnoses. Behavior interpreted through cultural stereotypes may be misunderstood. BAME families may be less likely to engage with services they do not trust or understand. Role of care workers in addressing inequality. Care workers play a frontline role in challenging inequality and promoting equitable access to care. This includes supporting individuals to prepare for and attend appointments, using communication tools, for example, visual timetables, easy-read leaflets, advocating for reasonable adjustments, such as longer appointments or quieter environments, recording and reporting barriers to access to managers and health professionals, encouraging annual health checks for people with learning disabilities, ensuring care plans reflect both health and social needs. Systemic and policy responses. Recent UK initiatives such as the Learning from Lives and Deaths Ladder programme, STOMP or STAMP campaigns, and NHS England's long-term plan emphasise the need to reduce health inequalities through training, data monitoring, and better integration of services. However, systemic change remains slow and inconsistent. Mandatory training on learning disability and autism, introduced under the Health and Care Act 2022, aims to improve professional awareness, but this must be paired with active efforts on the ground to dismantle everyday barriers. Common barriers faced in education, employment, and social life. 1. Barriers in education. Individuals with learning disabilities or autism often face unequal access to inclusive and meaningful education due to lack of early identification and support. Many pupils are not diagnosed early, resulting in delayed access to tailored interventions or education, health and care plans (EHCPs). Inaccessible learning materials. Standard classroom resources may not be adapted into easy-read, visual, or sensory-friendly formats, leaving learners behind. Insufficient staff training. Teachers and teaching assistants may lack training in autism or learning disabilities, leading to misunderstandings or inappropriate behavior management. Social exclusion within school. Difficulties with communication or sensory sensitivity can make it hard to form friendships or participate in group activities, increasing isolation. Rigid curriculum and assessments. A one-size-fits-all academic system can disadvantage neurodivergent learners who need alternative approaches to demonstrate their knowledge. 2. Barriers in employment. People with learning disabilities and autism are among the most underrepresented groups in the workforce. Barriers include workplace stigma and assumptions. Employers may wrongly assume that individuals with autism or those with learning disabilities are incapable of performing certain roles. Lack of reasonable adjustments. Many workplaces fail to offer necessary accommodations, such as flexible hours, job carving, or visual instruction aids. Complex recruitment processes. Online applications, formal interviews, and abstract questioning styles can disadvantage candidates with communication or cognitive challenges. Limited supported employment programs. Without schemes like job coaching or supported internships, many individuals struggle to enter or stay in work. Discrimination and bullying. Neurodivergent employees may face social exclusion, microaggressions, or direct discrimination from colleagues. 3. Barriers in social life and community inclusion. Social participation is vital for well-being, yet many people with learning disabilities and autism face communication barriers. Difficulty understanding or using verbal and non-verbal cues can make social interaction stressful or inaccessible. Sensory overload in public spaces. Noisy, crowded, or unpredictable environments can prevent individuals from comfortably using community facilities, for example, cafes, buses, cinemas. Public misunderstanding and judgment. Behaviors such as stimming, avoiding eye contact, or using alternative communication may be misinterpreted, leading to stigma or exclusion. Lack of accessible leisure and cultural activities. Sports clubs, arts groups, and social events often lack the adaptations or inclusive design needed for participation. Over-reliance on family for social connection. Without formal support, individuals may become socially isolated, relying solely on family members for interaction and activity. These barriers are not inherent to the individual, they are created by systems, attitudes, and environments that fail to accommodate difference. By recognizing and challenging these obstacles, care workers, educators, and employers can help build a more inclusive society where every individual is supported to thrive. Impact on families and support networks. When a person has a learning disability or autism, the effects are not limited to their personal experience, there is a broader impact on their family members, carers, and wider support networks. These individuals often provide essential emotional, practical, and sometimes financial support. While many families express deep love and pride, they can also experience strain, isolation, and a lack of formal help. For care workers, recognizing the pressures faced by families is key to building partnerships, reducing burden, and improving outcomes for all involved. Emotional impact. Stress and anxiety. Families may worry about their loved ones' well-being, education, or future, particularly when services are difficult to access. Grief and adjustment. Some experience a prolonged period of emotional adjustment following diagnosis. Mental health strain. Long-term caregiving responsibilities can contribute to depression, burnout, or relationship breakdowns. Practical and daily challenges. High levels of unpaid care. Many families provide round-the-clock supervision, often without breaks or respite services. Disruption to routines. Medical appointments, therapy sessions, and behavioral needs can dominate daily life. Complex navigation of services. Securing education, health, or social care support often involves excessive paperwork, repeated assessments, and appeals. Financial pressure. Reduced earning potential. Parents and carers may have to reduce working hours or leave employment altogether. Additional expenses. Costs may include specialist equipment, private therapy, adapted housing, or transport. Limited financial support. Delays or rejections in accessing benefits such as carer's allowance or disability living allowance add further strain. Social and relationship effects. Isolation. Families may withdraw from social activities due to stigma, behavioral challenges, or lack of accessible venues. Judgment from others. Misunderstanding from the public or even professionals can lead to blame or shame. Impact on siblings. Brothers and sisters may feel overlooked, take on caring roles, or experience emotional stress. Intersectionality. How gender, ethnicity, language, and socio-economic status affect experience and access to support. Intersectionality is a framework for understanding how different aspects of a person's identity, such as gender, ethnicity, language, and social class, interact to influence their experiences, particularly in relation to discrimination, opportunity, and access to services. For individuals with learning disabilities or autism, these intersecting factors can either compound disadvantage or serve as barriers to receiving timely, appropriate support. Recognizing and responding to intersectionality is essential for providing equitable, person-centered care. Gender and neurodiversity. Gender plays a significant role in how autism and learning disabilities are perceived and diagnosed. Historically, diagnostic criteria were developed based on male presentations, leading to underdiagnosis or misdiagnosis in females and non-binary individuals. Females are more likely to mask or camouflage autistic traits, making them less visible to professionals. Girls with learning disabilities may be perceived as quiet or compliant, and therefore not flagged for additional support. Gender expectations may influence how behavior is interpreted. What is seen as assertiveness in boys may be viewed as defiance in girls. These disparities can delay diagnosis, reduce access to interventions, and affect mental health outcomes. Ethnicity and cultural beliefs. Ethnic background can significantly influence how disability is understood, discussed, and responded to within families and communities. In some cultures, disability may carry stigma, leading to reluctance in seeking diagnosis or support. Behavioral traits associated with autism may be misinterpreted by professionals unfamiliar with cultural norms. BAME. Black, Asian, and minority ethnic individuals are less likely to receive an autism diagnosis and more likely to be misdiagnosed with mental illness. Structural racism within health and education systems can result in biased assessments, lower expectations, and unequal treatment. Care workers must approach each person with cultural humility, seeking to understand their background without applying stereotypes or assumptions. Language and communication. Language is a vital component of accessing services, expressing needs, and making informed decisions. Individuals and families who speak English as an additional language face multiple barriers. Complex documentation, online forms, and service communications are often only in English and may be full of jargon. Families may be unable to fully engage with professionals due to lack of interpreters or accessible formats. Miscommunication can lead to inappropriate care plans, misunderstanding of needs, or exclusion from decision-making processes. Care workers should always check whether interpretation is required and advocate for translated materials or visual supports where necessary. Socioeconomic status and access to services. Living in poverty or financial hardship has a profound effect on the ability to access and maintain health, education, and social care support. Travel costs, time off work, or digital exclusion can all impact a family's ability to attend assessments or engage with services. Families in deprived areas often face longer waiting lists, underfunded services, and reduced advocacy support. There may be limited awareness of entitlements, such as benefits or specialist support, particularly where there is low literacy or limited trust in public services. Housing instability or overcrowding can further complicate the delivery of consistent care or education. Those from low-income households often need more intensive support, but structural barriers frequently mean they receive less. A holistic, equitable approach. To address these intersectional barriers, care workers must adopt an inclusive and anti-discriminatory approach that recognizes each person's multiple identities and experiences, seeks out and listens to underrepresented voices, challenges structural inequalities and advocates for equity in care, makes reasonable adjustments not just for disability, but for language, culture, gender identity, and economic circumstances. Intersectionality is not a theory to apply after the fact, it must be built into every step of assessment, care planning, and service delivery. Thank you. You have successfully made it to the end of this module.